I'm sharing my screen.
Sir,
Okay.
sir, I am sharing for the initial part.
You are sharing in Silbert.
Yeah, until initial part, until I introduce you, I will share and then I will close sharing and you take over.
Okay, what I have to do right now?
Nothing, sir.
Okay, you
Absolutely
start.
nothing. Yes.
You start.
Yes. Good evening, doctors. Welcome to this webinar, Experience Sharing Program on Managing PPH, Case Studies from Labor Room, Experience with Carbetocin. Doctors, this program is brought to you by Hetero Healthcare. Hetero Healthcare, as you know, has got 25 years of excellence and 36 state-of-art manufacturing facilities. We have 300 plus products in portfolio and presence in 126 plus countries, 21,000 employees globally, and we are amongst the largest closely held pharmaceutical company. Hetero Healthcare is amongst the largest manufacturers of ARV, APIs, and FDFs in the world, and has Asia's largest API manufacturing facility as Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. Today's webinar, Experience Sharing Program on Management, on Managing PPH, we have got Honorable Speaker Dr. Basharat Pandit, who is a consultant gynecologist, and Honorable Co-Speaker Dr. Mohammad Yusuf Tak with us. Welcome, Dr. Basharat. We are waiting for Dr. Mohammad to join.
Thank you.
The speaker, Dr. Basharat Pandit, is consultant gynecologist, MD DNB, Kashmir. Co-speaker, Dr. Mohammad Yusuf Tak, is MD Anesthesia, District Hospital, Pulwama. So with this, sir, I will stop sharing and you take over the session.
Okay. Am I audible?
Yes, sir.
Okay. Hi. Good evening, everyone. I'm Dr. Basharat Pandit, consultant gynecologist, J&K Health Services. I welcome you all in this webinar, and the topic is postpartum hemorrhage and the role of carbetocin and my experience with carbetocin. So the definition of PPH, as all of you know, PPH is, as a conventional definition speaks, it is the blood loss of 500 ml in normal vaginal delivery, or the blood loss of 1 liter or 1000 ml in cesarean section. But in 2017, ACOG adopted a new definition of PPH. It is the blood loss of greater than 1 liter, irrespective of the mode of delivery, or any amount of blood loss which is accompanied by signs or symptoms of hypovolemia. Like if there is a blood loss and the patient has hypotension or tachycardia, it is PPH. PPH is very common, and it's not seen only in patients who are at high risk. It can be seen in any patient, anywhere, or anytime. PPH is the leading cause of maternal mortality and morbidity in our part of world. Maternal mort- mortality of India is very high as compared to the developed countries, which is just 16, but in India it is around 100. To be exact, it is 93 per lakh live births. 14 million women suffer from PPH. The incidence of PPH in normal vaginal deliveries is 2%, or it can go up to 5%, but in cesarean deliveries, it can go up to 10%. 38% of maternal deaths are due to PPH. Out of these, one one fourth of global deaths take place in India, and out of these deaths, two-thirds, that means 75% of these is because of PPH. So, coming on to the etiology of PPH, PPH can be because of the atonic uterus, it can be because of retained tissues or retained placenta, it can be because of trauma to the genital tract, or it can be because of coagulopathy. So, how will the patient of PPH present? The presentation of PPH depends on the amount of blood loss. We can have a patient with cold, clammy skin, with thready pulse, with tachycardia, with hypotension, with perspiration, with sweating. There can be anxiety on the face. The patient can be pale. uh, on palpation there can be atonic feel of the uterus. It is like the boggy feel or soft feel of the uterus, or uterus may be palpated above the umbilicus. The girth of the abdomen is increased. There is loss of uterine contractions. Or on examination or PV examination, there can be visible bleeding, or the patient can be seen in the pool of blood. The symptoms depend on the, as I already said, it depends upon the amount of blood loss. We have four categories of PPH or degree of shock, like category 1 or stage 1. It is a stage of compensation in which there is just 500 or 1 liter of blood loss. There is just one symptom like tachycardia or palpitation. There is no change in the blood pressure. In stage 2, which is also called as mild degree, there is 1 liter to 1.5 liter of blood loss. There is slight fall in blood pressure, but tachycardia can be seen or sweating can be seen. In moderate, there is 1500 to 2000 ml of blood loss, and there is marked fall in the blood pressure of the patient. The patient is restless, the pallor is seen, and there is decreased urine output in this patient. And the stage 4, that is severe degree, there is 2000 to 3000 ml of blood loss. There is profound fall in the blood pressure. There is circulatory collapse. There is anuria and there is air hunger. So, after diagnosing the PPH, we have to assess the patient and we have to resuscitate the patient simultaneously. The loss of blood or seeing the etiology of the blood and the resuscitation should go hand in hand. So, what should be our approach towards postpartum hemorrhage? If you feel there is atonic uterus, or the uterus feels relaxed, boggy, or soft, and there is visible bleeding, we need to follow the algorithm which is called hemostasis algorithm. In hemostasis, we H stands for help. We should call for help. The person conducting delivery should call the senior person, senior gynecologist. He or she should call anesthetist and other paramedic staff. Involve more and more staff as possible. Then E stands for establishment of etiology. We have to look for the etiology, whether there is traumatic PPH, or there is any retained tissue, or this is atonic. Then M stands for massage. Uterine massage should be given, fundal massage should be given, or then O stands for oxytocin. We should start oxytocin or prostaglandins. Then S, if there is bleeding after oxytocin, then we can shift the patient to OT. After shifting the patient to the OT, T stands for tamponade. Tamponade, we can do conventional tamponade like IV packing, intravaginal packing with the gauze, or we can use condom catheter or Sengstrom Blackmore catheter, or we can use Foley's catheter also. Then after T, it's A. A stands for application of compression sutures like Beeline suture, Cho stitch to the uterus, or Heyman stitch to the uterus. Then S stands for systematic pelvic devascularization, which means ligation of bilateral uterine arteries, ligation of bilateral ovarian arteries, followed by internal iliac ligation. Then I stands for interventional radiology. In the centers where interventional radiology is available, we should use interventional radiology in uterine artery embolization. Then, if the bleeding still continues, we can go for subtotal hysterectomy, and S stands for subtotal hysterectomy. So, this was approach towards the atonic uterus. Now, if there is trauma, if we are suspecting trauma, we should explore after. So, how can we suspect the traumatic PPH? If the uterus is contracted, if we see that there is firm uterus and it's below the umbilicus, it is well contracted, we should think of trauma. There can be trauma to the uterus, or we can call it as rupture uterus. There can be trauma to the cervix. There can be lacerations in the vagina, or episiotomy wound may be extended. It can also cause traumatic PPH. So in those cases, we need to explore the genital tract. If there is cervical tear, we need to explore the cervix and stitch it simultaneously. And after stitching the cervix, we can use IV packing, intravaginal packing. And if there is fornical tear, we need to stitch it back. If there is rupture uterus, we need to open the uterus, open the abdomen and seal the rupture. Or sometimes the patient can be converted into hysterectomy in case of rupture uterus. Or interventional radiology can also be used in traumatic situations like broad ligament hematoma or supralevator hematoma. Now, if there is retained tissue, if there is retained placenta, and PPH is because of retained placenta, we need to shift the patient to OT and give general anesthesia to the patient and do manual removal of the placenta. We can remove the placenta manually. Or if there are some cotyledon is missing in the placenta, we can we can remove it by ohm forceps or sponge holding forceps, or we can use anterior vaginal or retractor for removal of retained products or retained membranes. So another etiology is coagulopathy. When there is no trauma, the uterus is well contracted, we should think of coagulopathy. We should send all the coagulation profile, blood count, KFT, LFT of the patient, and start with replacement of blood products, platelets, or FFPs. So, in atonic uterus, we have to use uterotonic agents. Different uterotonic agents which are available right now with us are oxytocin, carbetocin, ergometrin, or methyl ergometrin, we call it methergin also. Symptometrin is methergin plus 5 units of oxytocin, and misoprostol or prostaglandin, or we can use carboprost or prostadine, we call it. So when are these agents used, or when oxytocin is used? It is used. It is administered at the time of crowning. It is used at the time of delivery of anterior shoulder. It can be used at the end of second stage at the when we clamp the cord or following delivery of placenta. Prophylactic use, it can be used in prevention of PPH, and it can be used in active management of third stage of labor. Or therapeutic use is management of PPH. Carbetocin, talking about carbetocin, what is the rationale, or why carbetocin? Because oxytocin and other ergot alkaloids should be refrigerated. They need to be kept at the temperature at about 4 to 8 degrees Celsius. Carbetocin is available at room temperature. It is stable formulation and is convenient, and it's available in convenient while presentation. Heat stable formation of oxytocin is currently not available. Poor resource countries do not have always cold chain transport or storage capabilities. So there was the need of the molecule which is stable at room temperature. It should have long half life, Like carbetocin, it has the shelf life of 24 months at 30 degrees Celsius and humidity 75%. It avoids the need of cold chain and other logistics. It is provided in vial. Carbetocin, talking about carbetocin, carbetocin is basically a synthetic analog of oxytocin. Carbetocin was created by making several modifications in oxytocin molecule to prolong its half-life or reduce its enzymatic degradation. The indications of carbetocin presently is only in the prevention of PPH, prevention of atonic PPH, and it is available in a vial which contains 1 ml of the solution, which contains 1 ml of the solution. Am I audible? Hello,
Yes, sir,
hello.
you are. Yes, sir, you are
I'm
audible.
audible. Okay,
Yes, sir.
okay. Uh, I was in the vial, na? Okay. So carbetocin is available in 1 ml solution in a vial which contains 100 micrograms of carbetocin. So clinical, what are the clinical evidence? Clinical evidence, efficacy and safety of carbetocin versus oxytocin. There is WHO champion trial, which is the longest, biggest trial in the history of carbetocin. Carbetocin decreased need of uterotonic agents versus oxytocin. Single dose carbetocin versus oxytocin. There are many studies, and we'll talk first oxytocin versus carbetocin. Oxytocin, as all of you know, is a synthetic cyclic peptide which comes from posterior pituitary. Carbetocin is a long-acting synthetic analog of oxytocin with agonist properties. Both of them bind to the oxytocin receptors, cause strong uterine contraction. Both can be given intravenously or intramuscularly. The half-life of oxytocin is just 1 to 6 minutes, whereas half-life of carbetocin is about 40 minutes. Oxytocin need to be stored at a temperature of 2 to 8 degrees Celsius continuously, but carbetocin is heat stable. It has no storage conditions. It can be stored up to 30 degrees Celsius. But oxytocin is used in induction of labor, augmentation of labor, and treatment of PPH. And carbetocin can't be used in induction of labor and augmentation of labor. But in prevention of PPH, yes, carbetocin is used and recommended in prevention of PPH, and it is also used in treatment of PPH also. So talking about Champagne's trial, Champagne's trial is the largest clinical trial in the prevention of PPH. In the large randomized double-blind non-inferiority trial, heat-stable carbetocin 100 micrograms intramuscular was compared with oxytocin 10 units intramuscular for women after vaginal birth. Primary outcome was blood loss greater than 500 ml or need for additional uterotonic. The trial found carbetocin was non-inferior to oxytocin. This result was pivotal for guideline uptake in low resource settings. So, in conclusion, carbetocin was non inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional uterotonics. Additional uterotonics were used least in carbetocin. Cochrane review, it is a study of it's a data of 11 studies involving 2,635 women which underwent cesarean section. Carbetocin resulted in statistically significant reduction in need of therapeutic uterotonics compared to oxytocin. Also, carbetocin is associated with less blood loss compared to symptometry in prevention of PPH for women who have vaginal deliveries and is associated with significantly fewer side effects. So guidelines and recommendations. Carbetocin is recommended by WHO. It is recommended by SOGC Canada. It is recommended by Renscock New Zealand. It is recommended by FIGO. It is recommended by Germany, Austria, Swiss body, FCOG France. Now sharing my experience with Carbetocin. I have used in high risk pregnancies. I have used in normal deliveries. I have used in cesarean sections. Recently, 2 3 months back, we had a patient in the labor room. Hanifa Akhtar, age 36 years. She was Gravida 4, para 3, previous 3 normal vaginal deliveries. Her gestational age was 37 weeks, 37 plus 5 weeks. She had the history of 2 PPH episodes in the past. She had anemia and gestational hypertension also. So normal vaginal delivery was conducted in this patient. Duration of labor was 8 hours. 3.1 kg of baby was delivered. Apgar score of the baby was okay. Placenta was delivered manually. So the risk factors here were previous history of PPH. She was a multipara. She had gestational hypertension. She had anemia, and her age was also on higher side. These were all risk factors for the PPH. So we used Carbetocin in this patient, 100 micrograms IV, and it was used immediately after the delivery of baby. The goal was to prevent PPH, to prevent atonic PPH. It was chosen over oxytocin because of single dose and efficacy and longer action. The outcome was a strong sustained contraction. There was minimal blood loss. No additional uterotonic was used. Vitals of the patient in the post-delivery room were normal, and she was discharged the next day. So discussion here is carbetocin shown to significantly reduce need of for further uterotonics. No other uterotonics apart from carbetocin was used in this patient. As it was a high risk patient, I used the carbetocin and I got the results. Single dose minimized the risk of missed administration in busy labor room. The labor rooms are quite busy wards. Mm, One nurse catering so many patients, there's a chance some dose of oxytocin is missed in the post delivery period. So administering carbetocin in these patients is quite good sometimes. It reduces nursing burden and improves safety profile in high risk deliveries. Carbetocin is highly effective uterotonic in high-risk pregnancies, offers reliable prevention of PPH with a single IV dose, especially beneficial in cases with history of PPH, anemia, and hypertensive disorder. This was the conclusion. And I have used carbetocin in cesarean section also. I'm in fact using this in every high-risk patient. Another patient we had was Ikrajan, 32 years. She was gravida 2 para 1, previous LSCS done for CPD. She was term pregnancy. She also had a history of previous PPH. In this pregnancy, she had gestational diabetes mellitus. She had a good size baby and polyhydramnios. So all the four factors were the risk factors for atonic PPH. She came to our labor room in emergency. She was in labor and emergency cesarean section was done. 3.8 kg baby was delivered with good Apgar score. Placenta was delivered completely. So the risk factors here were again history of PPH, polyhydramnios, good size baby. They all lead to increased uterine size or unduly enlarged uterus, which can which is a risk factor for atonic PPH. Carbetocin again was used in this patient. It was given immediately after the delivery of the baby, and the goal was to prevent atonic PPH. Outcome was a strong. Again, it was a strong sustained contraction. There was minimal blood loss, around 300 to 500 ml. No additional electrotonics were required again in this patient. Patient was quite stable in intra-op and in the post-op period, and the patient was discharged on day 3. So carbetocin again shown significantly reduced need for further uterotonics in high-risk pregnancies, reduced nursing burden, and improved safety profile in high-risk deliveries. Carbetocin is highly effective uterotonic in high-risk pregnancies, offers reliable prevention of PPH with single IV dose, especially beneficial in cases with prior PPH. Thank you.
Thank you, sir. If you can stop sharing, I will take over.
Okay, I'm stopping.
Yes, sir.
I stopped
Yes.
sharing.
Yes, sir. I will take over.
Okay. I'm not hearing you.
No, no, 1 minute, sir. 1 minute.
Okay.
Can you hear me now, sir?
Yeah.
So thank you very much for those cases. Really interesting. We got insights in what are the risk factors truly. And I suppose, sir, anemia is a major risk factor in our country, should be.
Yeah.
What is the patient profile where doctors can anticipate a PPH?
Is this question for me?
Yes, sir.
So, PPH can be anticipated in patients where there is increased abdominal girth, like polyhydramnios, twin pregnancy, multiple pregnancy, fetal microsomia. It can be anticipated in patients with which have previous history of PPH in placenta previa. In those patients where labor is induced or augmented with oxytocin, where the patients have prolonged labor or precipitate labor, both can go into can land into the PPH. So these are the patients we have, or we can anticipate PPH.
PPH. Can we use carbetocin in case of a retained placenta?
Retained placenta. In retained placenta, we need to see first what is the cause, why the placenta got trapped, and it is diagnosed after half an hour of the delivery. If the placenta does not deliver up to half an hour after the normal vaginal delivery, we call it as retained placenta. So we need to look if it is if it is not morbid adherent placenta, like placenta
Okay.
accreta percreta, that should be ruled out. Okay, so if this is not the case, then we can go for manual removal of placenta. At the time of manual removal of placenta, we can use oxytocin, not carbetocin. 10 units of carbetocin intramuscular or IV is recommended at the manual removal of placenta. After we remove the placenta, we can use carbetocin at
Okay.
that time. It is recommended only after delivery of the placenta.
Only after delivery of
So
placenta.
to prevent the further PPA, to prevent atonicity,
Okay.
that can occur after the
Delivery of
removal
placenta.
of placenta. So you got my point. So
Yes.
there is a role in retained placenta, but it should be removed first manually, and then we can use carbetocin.
Correct. Got it, sir. In case of RH negative mothers, sir, your opinion?
The safety profile of carbetocin is same as oxytocin. As other studies are saying, there is no harm in giving an RH negative mothers, same as oxytocin. So we can use carbetocin in RH negative mothers.
If a doctor, can a doctor use carbetocin for prevention if they use oxytocin for induction? I mean, most of
Yeah,
yeah,
carbetocin can be used after oxytocin. If
induction.
oxytocin fails in PPH, or it can be used after that also. There is no question of using after induction of labor. We
Okay.
can use it definitely after induction of labor, because oxytocin has very less half life.
Okay.
The half life of oxytocin is just 1 to 6 minutes. So
So
after
we,
we can use definitely we can use carbetocin after oxytocin administration.
of course, you prefer IV route, so I will not ask this question.
So I
Any side effect of carpetocin you have seen, sir?
no deadly side effects, but if we will use when we use IV carbetocin, we can have a little hypotension or
Hypertension,
tachycardia or little headache in these patients. Nothing, no major deadly.
transient.
Yes, it's transient, but no deadly complication. The safety profile is same as
Then
carbetocin.
advantages of carbetocin over other uterotonics.
Yeah, carbetocin as I already I said, this is heat stable component.
Yes,
So other uterotonics need to be refrigerated.
correct.
So this is the single dose. We can use a single dose, but like oxytocin, we have to use an infusion. So and it has to be run for hours. So there is no need of this thing in carbetocin.
Yeah, that's a major country. I mean, storage conditions a major thing.
Yeah, storage condition. That's why the heat stable component has they have produced.
Correct, correct.
They have made.
Should it be kept as a reserve drug? I mean, you have been using it as a first line in high risk patients, but
Yeah,
otherwise
in
also
high risk patient, I use it as first line.
first line.
First line, yeah.
Otherwise,
I
the
I don't compromise with the safety of
yeah,
the
yeah,
patient.
yeah, correct.
No com- yeah.
Sir, anesthetic Dr. Yusuf, would you like to take this question, role of anesthetist versus gynecologist, vis-a-vis gynecologist in choosing a drug in prevention of PPH?
Role of anesthetist, Dr. Tak, are you listening? You are not audible. You are
Yeah,
Dr.
yeah,
Tak.
he's.
I'll join in. I'll join in.
Yeah,
Dr.
yeah,
Prashant
joined it. Sarah
sir,
joined it.
I
Dr.
will
Prashant
add
sir, very
I
good
will add
evening.
one
Dr.
line
Basharat
before
sir.
the talk before Dr. Tak takes over the question.
Okay.
The, it's not the role of anesthetist is not only in the preventing or in life saving life of the patient. It's the life of the gynecologist also in the hands of anesthetist
Oh, so nice.
that time. So anesthetist, backbone of the hospital and backbone of the OT,
Absolutely.
is dealing with the life of both patient as well as the gynecologist.
In one line, you have described everything, sir. Wonderful.
So
Thank you.
please talk.
Dr. Prashant, actually, yes, I'll be coming in now.
Yeah,
This the a wonderful gynecologist makes the life of an anesthetist very comfortable.
absolute,
And Dr.
absolute,
Basharat is one among them because we work together.
absolute. I mean, they're
So
complementary essentially to each other.
it's a team. It's a team, and
Yeah,
you
correct,
know each
correct,
other
Yeah,
correct,
it
it's a
matters a
team.
lot.
correct, correct, correct.
So when we speak about management of PPH, as an anesthetist, I would just like to share two cases with you.
Huh,
Just managing a PPH vigorously, also that's also a problem. Just
oh,
being lazy, that is again a problem.
correct.
So I remember a patient. She was 27 years old. She was gravida 2, and she was with placenta previa, was with PIH, and her gynecologist said advised her to report to medical college for her cesarean.
Huh,
She landed up with the accidental hemorrhage and ended up with us at district hospital. We called a surgeon colleague with us and we went for subtotal hysterectomy. We took the baby out, went for subtotal hysterectomy, but the cervix bled so much that we had to go for massive transfusion. After transfusing 7 units of blood, we were still not able to control her bleeding. It
my
was
God.
oozing over there.
It was in fact
Then
the
we
placenta
shipped
percreta, I
it.
think.
It was it was percreta. It was just
Yeah,
this
outside. It
catching
was with
catching
the
the whole
blood.
cervix. It
Hmm.
was catching the whole cervix. So then we got in touch with the people in medical college, and when we shifted the patient to medical college, we spoke to surgeon. Surgeon said, "No, this is a case of gynecologist." When we spoke to gynecologist, he told, "No, uterus is out, baby is out. How come we are in?" Then physician told, "No, this is operative case." Then that lady she went underwent internal iliac ligation, and she was saved.
God bless.
Again, I had a patient. She was 25 years old. She was gravida 3. We did the cesarean sections. We had a couple of cases more to do. When we finished the cases, we found her in a pool of blood,
Oh,
and she was pulseless. So we pushed blood. I pushed 4 units of blood, and she developed pulmonary edema.
oh my God.
Now all froth was coming out. So just at a periphery, it was again a challenge. We made just a CPAP circuit over there, kept the patient with support for almost 4 hours, because it was not wise for us to ship the patient in that unstable condition. She would not
Correct.
make it. So once we speak of anesthetist's role in PPH, it's really tricky. One has to be
Absolutely.
smart enough and one has to be quick enough. So the first thing, we assess the patient. While assessing the patient, we have to start the resuscitation.
Very
When
true.
we talk of PPH, we start oxygen supplementation. We can just give it by way of a nasal cannula, or if it is we want FIO to be more, we go by way of aerosol face mask. At the same time, a patient is already with IV line, so we push some more crystallites. Ring electrate is the ideal one, and if the volume loss is more, we definitely go for the Clyde. And then we keep blood ready. Basically, ideally, we should be having 4 to 5 pints of blood ready, cross matched for these patients. And as you rightly said, we go with the oxytocin. Then we go with this carbetocin, as we were discussing. It has just made the life easier. Like every passing day, these things are making the life of the gynecologist, the life of surgeon, very comfortable.
That's very
Carbopros
nice.
as we give, and then the second thing which we're telling, this carbetocin. Carbetocin, again, one more thing which we're using up now. It is really, uh, as we have seen the results, even for the normal pregnancies, it's very good. Then in cesareans, then in selected cesareans, this is very, very good, because as Dr. Bashar was speaking about the potency of the drug, then it is heat stability. Because now what we're going to do in our place, we're going to keep our fluids warm. So keeping the fluids warm, and then the heat stability, it's very good. Though in our place, this
This is the point. This is the
refrigeration is
point.
not a problem. It's not a problem,
Exactly.
because we have the temperatures are cold. We don't need
Correct.
refrigerators for most of
Correct.
medicines here.
Yeah, yeah.
But then the Carbifrost, we have seen it has made the lives of the gynecologists and surgeons very comfortable. As you, Dr. Prashant, sir, you rightly said in the beginning, the role of PPH, it is both the gynecologist and the anesthetist.
Absolutely.
The role is not separate. It is just a team,
It's a team.
and
Correct.
the
Correct.
the outcome is excellent when the team works in tandem.
Absolute.
Uh,
No doubt about it.
that's
100%.
very vital.
Correct. Thank you so much, sir. Thanks, for all these insights. I'm sure the audience has benefited out of this. Thank you very much, sir. And Dr. Yusuf, you have explained in such a humorous way the serious problems. I mean, it's lovely.
Thank you, sir. Thank you.
Thank
So
you.
nice.
Thank you so much. Thanks, Basharat, Dr. Basharat.
Thank
Now,
thank
take
you.
home message for the audience.
Take home message for the audience is carbetocin is a wonderful drug. It is effective uterotonic for preventing PPH, offering longer lasting action. Uterine contraction is so good than oxytocin, with added benefit of heat stable formulation, suitable for low resource countries like India, but the only limitation of is cost.
Cost.
Yeah, otherwise it's wonderful.
Thanks, sir. Thank you so much. Thanks for all your insights. I thank all the doctors who took time from their schedule and attended this. Thanks, Dr. Bashara. Thanks, Dr. Yusuf. It was lovely listening to your webinar. I mean, your insights, practical insights. These practical insights, I'm sure, will help the doctors more than the theory references. Thank you. Thanks, the sales team, marketing teams, and thanks, Sanjana, for your IT support. Thanks once again, doctors. And you can sign off. Thank you. Wish you a very pleasant evening. Thank you. You can sign off, sir.